Okay, so we left off in the lecture and anesthetic problems that you can encounter. And then now, the ultimate problem nobody wants to encounter is if we have an actual cardiac arrest, which literally, by definition, there's a cessation of circulation. And what happens if the heart stops, then the heart does not pump blood to the tissues. The tissues do not get oxygen, and therefore cells die. And if the brain doesn't get oxygen and the nervous system doesn't get oxygen, it puts the animal in a very critical situation. A lot of times, I would say the majority of the time, you're usually going to see some abnormal electrical activity, which then typically we know potentially cardiac arrest is coming. I think I've told you guys before, sometimes I look at an ECG and take this to heart. It starts to look kind of wide and it starts to look bizarre. It just doesn't look like a normal, nice, tight PQRS complex. So, and I will tell you, like when I was before that dog arrested in surgery not long ago, it sped up, it slowed down, it sped up, something sounded very strange. So a lot of times I tell you guys when there's impending cardiac arrest, it's pretty rare that an animal is actually going to be 100% normal and then go into spontaneous cardiac arrest. I did have that happen with a patient in radiation. Right after induction, went into immediate cardiac arrest. And the dog had several problems: brain tumor, heart disease, was an American bulldog. So, but most of the time they give you breadcrumbs, which I call clues. And maybe there was abdominal breathing, maybe there was abnormal ECG, maybe the heart rate plummeted, maybe their respiratory character was off, maybe the eyes are central and dilated. So usually there is a clue. Now, a lot of times when the heart stops, respiratory arrest is going to come immediately after or very soon after. So that dog that arrested, the heart stopped, and then there was a cessation of breathing. It kind of happened back to back. So how do we know? Well, the heart sped up, slowed down, sped up, and then all of a sudden, Mrs. McClure couldn't hear a heartbeat. She listened with her stethoscope. She put her hand on the chest. Immediately, if you are suspicious, you need to confirm, and that does not mean staring at an ECG because that is electrical activity. What that means is you got to get ears on the dog, you got to get a hand on a pulse, put your hand on the chest, and we have to figure it out. If you don't hear a pulse, if we're getting a really, really, really low blood pressure or no blood pressure reading, and then immediately, and this sometimes isn't right then, but eventually their color is going to get almost a gray, bluish color because there's no circulation, so you're not getting a CRT. And then the eyes are very telling. I told you, looking at a dog's eyes during anesthesia tells me a ton. If I look at their eyes, are they central and dilated? It's like they're looking at you, but they're looking through you. It's a very eerie feeling. So when an animal has passed or is in cardiac arrest, their eyes are often central, pupils are dilated, and sometimes instead of getting a respiration, you get these like gasping, what are called agonal breaths, and that's the brain's last ditch effort. There is something called the phrenic nerve, and the phrenic nerve connects the brain to the diaphragm. And what the brain will do will try to create this like diaphragm to spasm, and that's why the breath looks, and that's another eerie thing. And what they're trying to do is to try or trigger some kind of a breath, except that it's not causing a breath. It's kind of causing this. So what happens is they're going to follow each other. And then if we do not get oxygenation reestablished, so what you have to do, remember I said you have about 5-10 minutes to be successful. So basically, we have to start resuscitation. And what we have to do by doing cardiac compressions and bagging, you're trying to force circulation to the brain. So hopefully cells in the brain do not die. And that's what we have to get established. And that's why it's critical to pay attention, because we have such a short window to be successful. Some of the things that we talk about, there is a new thing called Recover, Reassess campaign on veterinary resuscitation. So people are always studying the newest thing in CPR. What are they doing in human medicine? Can we apply it to veterinary medicine? But there are a little bit of differences. We go from basic life support, which is what we initially do, and advanced life support is what we assess if we think we're starting to be successful, and what are some things we have to do to take care of the patient if we get them back. Return of circulation and return of spontaneous circulation is where the heart starts to beat on its own again and it starts to circulate. Because when we are doing CPR, we are trying to create circulation by pushing on the heart and push blood through the body and to the brain. But what we're really wanting to see is that the animal's heart begins to beat and they create what's called spontaneous circulation, which is their own circulation. And then if we get them back, we got to do with something called PAC, which is post-arrest care. So I do want you to be familiar with these terms. Now, we have to be ready for CPR. This is why I say it's critical that you guys do scenarios in your practice. Do practice CPR. And, you know, like I said, you can be a stuffed animal and you could all practice, okay, I call you from up front, I bring you out of surgery. We all have to know where is our emergency drugs, who's bagging the patient. Ideally, you're going to have 3 to 5 people helping you. I think, like I said, when we worked on that dog, there was like 6 of us, 7 of us in there. And so, you know, obviously we have more staff and everybody just, you know, if something happens in our dogs in the kennel, we all drop our classes, whatever we do, we come running to help. So how do we go about this? So basically here's like an algorithm, which is like a chart. And a lot of clinics will print something like this and put it on the wall in several locations so everyone can aware. But if you see patient not breathing, not responsive, then we're going to start with our basic life support, which is compressions and ventilation. And then when we start to get into advanced life support, this is what you need to start. We can do monitoring, try to get an IV. Now, this looks like it's all separately done. The more people you have, you might be doing this all together. One person's doing compressions, one person's breathing, one person's making sure hopefully your patient has an IV. If they're under anesthesia, ideally they have a catheter. And one person is getting the drugs, like usually someone's trying up epi, atropine. Can we reverse anything? Once we've started CPR, eventually what we're going to do is we're going to try to evaluate. Sometimes we have to pause and have someone listen and look at the EKG. Do we have any electrical activity? Even if it's not normal electrical activity, sometimes you'll see a little bump. We know the heart's trying to start. We know that the electrical system is trying to kick in. So sometimes in CPR, any little electrical activity is a good thing. And sometimes you look at the ECG, and then you are going to assess, do we have ventricular tachycardia, or VF is ventricular fibrillation. Now, you see how it says pulseless. Sometimes when the ventricle pumps so fast, ventricular tachycardia, you guys, I've talked about this in physiology before. When a heart beats and when it relaxes is when it fills. The faster your heart is filling or beating, the less time it spends filling. So sometimes you can have such a fast tachycardia that it doesn't beat enough blood out to create a pulse. So you can see ventricular tachycardia and you may feel for a pulse and you don't feel an adequate pulse. It may be that the heart is beating so fast, it does not have time to fill, and it doesn't, in that way you don't get a pulse. Then you may have to defibrillate. If you check the EKG and it's a straight flat line is asystole. Systole is contraction. Asystole is without contraction. Or you have what's called PEA, which is also called EMD, pulseless electrical activity. That means, if you remember, you have an ECG tracing, but you do not hear a heartbeat and you do not feel a pulse. Because in some cardiac arrests, the heart actually stops. And I told the story about when we euthanized the dog at Purdue, my anesthetist lost the heartbeat right away. But the EKG was normal for 10 minutes. That's PEA or EMD. That means that the ECG, the electrical activity works, but you need mechanical activity, which is the actual pumping. So this would be epinephrine, potentially atropine. The doctor is going to tell you which to give and, whether you give a full dose. We might consider, sometimes you start low epi and increase the epi if the first round of drugs doesn't work. And then we usually, every couple minutes, try to change the person doing chest compressions, because believe it or not, it is very taxing, very exhausting to do CPR. So I want to say in that room, we all were taking turns. I'm like, it's my turn, it's your turn. And we changed positions just because the person would get tired. Now, what we do in basic life support, they're non-responsive. You have to do this quickly. You have to determine, are they arrested? This is not when you want to go, I hear something, maybe put your hand on the chest, put your stethoscope on the heart, try to feel a pulse, determine. And if immediately when Andrea or Mrs. McClure confirmed that she says, I can't hear a heartbeat, I went in there and I tried to feel, and I couldn't feel anything. I immediately started compressions. The dog was intubated. So somebody needs to, usually the first thing is to establish an airway, but somebody should start compressions. Make sure there's an endotracheal tube, make sure you have oxygen, make sure the tube is not kinked. And then you're going to start bagging the dog. So normally, if we do 100 chest compressions a minute, about every third to fifth compression, you give a breath. So again, I usually watch my compressor and I go 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 1. And you want to squeeze the bag as they push because you increase the intrathoracic pressure, which helps push blood. So ideally you do that together. Now you want to do high quality compressions, 100 to 120 beats a minute. And it's a kind of a joke if you watch The Office. There's actually a funny skit about this, but it's to the tune of Staying Alive, like, staying alive. Because I've seen people do CPR and they're like freaking out. And I'm like, no, it has to be, staying alive. So it's kind of like think of a song, has roughly that beat. Because probably maybe some of you haven't heard about Staying Alive. And you want to compress about a third of the chest. There's another thing that I want to mention. There's the cardiac pump and the thoracic pump. And then there's some notes under here about something called abdominal compressions. They are also called abdominal counterpulsion. And this takes, if you have enough people, one person's breathing, one person's compressing the chest, and the other one pushes on the abdomen after every compression. Do you see we're creating a pump? So hopefully blood goes in a circular motion throughout the body. So usually the compressor and the abdomen compressor alternate. 1, 2, 3, 4. Okay. Here are some images of putting your hand over hand, and you want to use the heel of your hand. You guys will also go over more advanced CPR directives in ClinMed 5. You go over emergencies. Now, if you have a barrel-chested dog, like a bulldog, they say that chest compressions, because their chest is kind of wide, They say it's better to put them in VD and push on their sternum. If you have a shepherd or a lab or something, if you put them on their side, what you're trying to do is, if you look where these hands are, okay, they've got the dog up against them so they don't push the dog off the table. Also, it's their hand is on the ventral chest, because what you're trying to do is the ventricles are at the bottom. You're trying to push on the ventricles and force blood out of the heart. Now, in a cat, you can do this with one hand. Like, we don't ideally want to break ribs. If you push, if you're a really strong person, you know, you could fracture a chest. It's been done before. So you have to put enough pressure. If there is no endotracheal tube, this is good for first aid. If you're outside walking a dog and something happens and you don't have a machine or ambu bag or a tube, you can hold their mouth shut and blow through their snout. And that's better than nothing. But ideally, they'll be intubated and you'll be on a bag. So ventilation, they need to be endotracheally intubated, usually on their side, usually right or left lateral. And if you're doing roughly 10 breaths a minute. I'm not really calculating tidal volume, but if you look on your, like when you bag a patient for anesthesia, you go to 20, you're going to do the same thing here. You're going to bag to 20, and then you're going to do bagging. If you're doing mouth to mouth, if you're by yourself, God forbid, you would breathe in their nose, do 30 compressions, 2 breaths, 30 compressions, because obviously you can't do both. So you do sometimes have to stop and breathe in the nose and then go back to compressions. But if you guys are in surgery with a full crew, the person that's breathing, make sure the tube is clear, make sure you have oxygen, make sure your vaporizer is off. Remember, that's the first thing you do is turn off your vaporizer, and then you give it. Now, this is key. You do not stop compressions to give a breath. So again, the person giving the breath gives it at the same time as compression. Now, that's starting basic CPR. Hopefully now someone can get into some advanced things. Put on an ECG, and if you can, put on a CO2. Now, I think I've started to give this lecture and then I ended it, the previous video. The only reason they say not to use alcohol is if you have a defibrillator, because the electrical shock mixed with the alcohol will set the animal on fire, which is nothing. Excuse me. Okay, they did not appreciate the UPS driver. Okay, so the ECG, the only reason to not use alcohol is if you have a defibrillator, which I said most practices and clinics do not have a defibrillator. If you're just doing an ECG, you can use alcohol. The other thing is what a capnograph is good for. If you are pushing hard enough on the chest, you will look at your capnograph. Remember I said a capnograph gives you a CO2 tracing, it goes up and down. If you actually see that moving, that shows that you're moving air. And also when you get circulation back, your CO2 values should improve. Now, you're probably not going to get a CO2 of 40 or 50. You might get a small tracing, but that tells you, it's nice because it tells you that you are getting it. Now, there is a thing here that says the capnograph can monitor the quality of the chest compressions. If an animal is in true cardiopulmonary arrest, you have a CO2 of 0 because you are not getting circulation to the lungs. When I said that I had a patient arrest spontaneously, how I picked it up was I induced the dog, I tubed, I tied in my tube, I turned around, I hooked up the oxygen, I turned it on, and the first thing I always do is I give my patient a breath immediately. I gave the patient a breath, I saw no CO2 tracing, and I knew I was in the trachea, and I knew that intubation was second. But as soon as I saw that I had no CO2 when I bagged, I put my hand on his heart and I confirmed I had no heartbeat. But I picked it up by looking at my CO2. You only get CO2 if you have circulation to the lungs. Now, when this is a little bit, only a little bit of CO2 in air. So when you're doing compressions, you might get a little bit of tracing. That's what all this is explaining under the slide. So make sure, if you guys view this PowerPoint in your notes window in PowerPoint, it shows you, I hope you guys are reading the notes underneath the slides because it goes into a little more detail. Now, part of us is also getting vascular access. You guys in surgery, your patients will have an IV catheter placed because you're giving fluids. In practice, some people for quick surgeries don't put in IV catheters. They hit the vein with a needle and give the propofol. That is riskier because in the event of an emergency, it's very difficult to catheterize a dog in cardiac arrest because they don't have circulation. So it's much more difficult to get vascular access after the fact. So hopefully you have a catheter in. If you have a tiny patient, you can use an IO, which is intraosseous, which you usually put in the femur, at the very top of the femur. If you cannot get an IV catheter and you can't put in an IO catheter, you can give emergency drugs down the endotracheal tube. But what you need to know is that you have to double your doses. You have to double your doses when you go what's called TT or transtracheal. Because what I normally do is the doctor will put a little catheter on the end, we squirt it down the endotracheal tube, and if I'm the person bagging, I squeeze the bag very deeply 3 or 4 times to blow the drug into the lungs, and hopefully, because again, the heart is right by the lungs, and all the blood from the lungs is going to the heart, so hopefully that drug gets into the lung tissue, gets into the capillaries, and gets to the heart. This is extremely controversial. In very bad cases, I've heard of doctors giving it intracardiac, actually injecting the drug. The problem is if you get that dog back, you can cause bleeding in the heart. You can cause arrhythmias because you injure the heart muscle. So it's very risky. I mean, some people are like, what do we got to lose? I mean, I guess if you had a bad CPR, maybe, but there's a lot more routes that are more beneficial to the patient. Definitely, if you have a reversible drug on board, get the drug out of their system. I already told you the 2 main drugs that we reverse is dexmedetomidine and pure opioid agonists. I've already told you buprenorphine and butorphanol are not reversible. So if I have a dog, I've seen people say I'm going to give Narcan or naloxone with butorphanol, but part of butorphanol is an antagonist, and now you're giving another antagonist. So again, you're not going to get, and usually butorphanol doesn't have profound enough side effects that you have to reverse the patient. You can't reverse ACE. You can't reverse propofol. The way you get rid of ISO is you turn them off. And then those are about the only drugs that you're going to reverse if you can. Now, while we're doing this, about every 20 minutes or so, we pause. Sometimes we pause every 10 minutes. We change people and then evaluate pain for return of spontaneous circulation, ROSC. That means everybody, because if everybody's pushing the dog and you're trying to feel a pulse and the dog is being jostled, you can't feel a good pulse. So sometimes everybody just has to stop so somebody can listen and somebody, do we have a pulse? Do we have electrical activity? Do you hear a heartbeat? If not, we're going to start. Go back to CPR, go back to bagging. Look at your ECG. Is there any electrical activity? Do we see any evidence? And again, when you're giving CPR hooked up to an EKG, your EKG is going to pick up movement. That's why you need to stop and just stare at the ECG and see, do you see spontaneous activity? So how do we confirm we have circulation? I've just explained. Feel the femoral artery, feel the lingual artery. Do you feel a pulse? Do we have a QRS, a PQRS complex on ECG? Can we hear a heartbeat? Are we getting CO2? Remember, during CPR, you might get a CO2 of like 5 or 10 because you're compressing. But if an animal has circulation, they are going to have a normal or an elevated CO2 reading. So that's I love CO2 for that. To me, a pulse ox in this situation is not beneficial. You can try to get a pulse ox, but your ECG and CO2 are going to be your best determinants for, do I have circulation? Have I got the patient back? And then you have to bag for them until they breathe for themselves. If they're not breathing on their own, you need to continue to bag for them. So I've already talked about reversal agents, try to get anything off a board. And then your CPR drugs, again, somewhere in your clinic, I know I've seen a couple different things. Sometimes there's a chart and it says animals 1 to 10 pounds get this much atropine, this much epi. 10 to 20 pounds, 30 to 40. And there's just a simple chart. So how much does your patient weigh? Go over this much atropine, this much epi. More clinics now are doing anesthesia forms in the computer, and they automatically calculate emergency drugs. And if they don't, and you are worried about your patient, I used to create for my high-risk patients, because we didn't have that at Purdue. We had to calculate everything by hand because I'm old. But this was several years ago. So I would just look up the emergency dosages. We would have them in the emergency cart, and I would have calculated for my high-risk patients CPR drugs in the anesthesia chart. So if something happened, the drugs are already calculated, draw them up, okay? Now, when we start to get into this advanced, have we gotten the patient back? You're going to look at your ECG and see what you're showing. Again, commonly asystole is a flat line, just nothing. Pulseless electrical activity is a fairly normal ECG tracing, but you cannot hear a heartbeat and you cannot feel a pulse. So technically the dog is clinically dead. Even though you have electrical activity, it's not generating a pulse. And that means that the heart isn't functioning. Fibrillation is where you get a bunch of the squiggly lines, and that's ventricular. Again, when a ventricle is fibrillating, the muscle is, instead of going like this, the muscle is going, it's quivering, and it's not generating a beat. And then ventricular tachycardia, whereas the heart rate is so fast that it's not pumping efficiently to create a pulse. And again, if you do not have a pulse, you do not have perfusion, brain is going to die, cells are going to die. It sets up a very bad situation. So you have to get adequate pulses. So how do we get the heart to beat normally if we do pick up some of these things? If you have asystole or the pulseless electrical activity, we usually use epinephrine in that situation. Vasopressin is a drug that's going to cause vasoconstriction and hopefully give us a blood pressure. This is classic. If you look at this ECG right now, I mean, I hope that looks kind of wide and bizarre. This is like a tracing. It's not really a VPC. It's similar to a PVC or VPC, but this is not generating a pulse, which means there's no perfusion. Here's the squiggles, and then here's ventricular tachycardia. So again, this looks, now in this situation, this is better than asystole. The dog has electrical activity. This heart and this heart, we may have a stronger chance of getting those patients back with the right treatment. Our dog that arrested the other day in surgery was asystole. There was literally a flat line, okay? You also get a flat line if your ECG clip falls off. So before you panic, I mean, you always confirm you can hear a heartbeat or feel a pulse, and then you can check your ECG leads. So epinephrine, atropine, sodium bicarb will help stabilize the cell membranes in the heart, will help treat acid-base problems. Okay, there's some doses there, obviously. I just want you to know some drugs that treat asystole. Now, what do we do for fibrillation or VTAC? When you're in, you need usually a defibrillator. You can use antiarrhythmic drugs. Lidocaine is one. Amiodarone, I've not used that one. But the other thing you can do is, Dr. Paul even tried it in that dog, is you do it something called a pericardial thump. He literally hit the dog on his chest super hard, like he just went thump. And I'm sure we had some new students watching. They were probably like, why the hell is Dr. Paul hitting this dog? Sometimes what you're doing is you can hit the heart. They say to do this in people. I mean, if you don't have a defibrillator, you got to try something. Sometimes you can thump it, and that electrical activity sometimes can straighten itself out. I mean, a defibrillator is the gold standard, but that is the next best thing. Now, this is very rare. If what I just described this whole time is what's called closed chest CPR. You're doing external compressions. Okay, you're pushing on the chest. In certain cases, and I've seen a few of these cases at Purdue. We had a dog arrest in the CPR. The doctor cracked the chest, put his hand in, and did what's called open chest. So they make an incision between the 7th and 8th rib. They open up the chest and literally hold the heart and pump it with their hand. Now, the chances of that being successful is almost nil. There's a lot of doctors that they're like, I'm not going that far, because now you have an open chest. So if this dog comes back to life, now we have to do a surgery to close his chest. Now, once the chest is open, the person bagging cannot stop, because an animal cannot breathe on their own if they have an open chest cavity. Now, these dogs aren't breathing, but say you get them back and the animal starts to try and breathe, until the chest is closed and the air is sucked out, you cannot stop breathing for that patient. Cannot do it. But open chest CPR is not successful, typically. Now, say we get them back. Yay. And it does happen. I don't want to be all doom and gloom. I didn't go over a list of why cardiac arrest happens. It can be from overdose, too deep. It can be the pop-off was closed. It could be the nature of the procedure. It could be a dog's pre-existing condition. So I kind of think of like, why do animals go into cardiac arrest? But if it is just an overdose, we have a lot more success with that, because we can reverse drugs, we can turn off the gas, we can start bagging with oxygen, get the anesthetic out of that dog's system, and then hopefully we get them beating and breathing again. But you're going to have to watch these animals closely. They have to be watched in an ICU. If your clinic does not have somebody 24-hour care, they need to go to a 24-hour care facility, because there is a very common occurrence of another cardiac arrest. Anesthetic emergencies, that's not as common. But if it was a cardiac arrest for another reason, they are at a very high risk of a second arrest, and you need them being monitored. Again, we have about 5 to 10 minutes to be successful in CPR. So that's CPR. Some other problems that we can deal with. Now, this is going into recovery. So now, this isn't recovery from CPR. This is what are some problems that we see in animals, all animals after surgery that are problems after. So regurgitation is something that we battle. And it's a passive. Okay, they're asleep. So they're not actively regurgitating. What's happening is fluid is just draining from the stomach up the esophagus, and a lot of times it comes out in their mouth and sometimes their nose. I've had patients, and I know it sounds weird, they're like blowing bubbles, when they're waking up, when they're in recovery. Sorry, they're not going to blow bubbles if they're intubated because they're not able to breathe through their nose. But I've had animals that have woke up and then all of a sudden I see the bubbles, and that means they probably had some regurgitated stomach fluid in their nasal cavity. Stomach contents, what you have to realize, are extremely acidic. The pH of stomach fluid can get as low as 2.0. So somewhere like 2.0 to 4.5. So that's very irritating to the tissues of the nasal cavity, of the trachea, and especially of the lungs. The big thing we worry about with regurgitation is any fluid that comes up into the nasal cavity or the pharynx. Is the animal going to inhale that? Now, if it's during surgery and the cuff is inflated, regurgitated fluid shouldn't be able to get into the lungs. You should be safe. But if we have the animal extubated and they're swallowed, this is why we wait. This is the exact reason why you don't pull a dog's endotracheal tube or a cat or whoever until they're swallowing, because by the time they swallow, they have their laryngeal reflexes back. So theoretically, if that animal puts their head back and some of that fluid starts to go in their trachea, they should cough, or they should be able to close their larynx and prevent that stuff from coming in the airway. Okay, so probably what you want to do, it tends to happen when you have a surgery where the animal's head is positioned lower. Normally an animal is flat during surgery. Sometimes their head is tipped. And this is why we're cautious in ruminants, because remember I said ruminants are very prone to regurgitation because the fluid sitting in their rumen, when you anesthetize them, can just migrate up into the airway. So what do? Clean out regurgitated fluid with suction. So, I talked about suction in cows, but in dogs, we always had suction in surgery and emergency. So you can do that. Now, vomiting during or after anesthesia is typically happening if they are very, very light under anesthesia or once they're regaining consciousness, because vomiting is an active process. They have to be awake. So usually, I think we've all seen your dog kind of go, you see it's coming. Again, if an animal is anesthetized, on the table, they shouldn't be able to vomit. So if they are vomiting while they're asleep, then they're not adequately anesthetized. They're too light. Okay, so when does this happen? If you decide to do surgery, say a dog was not fasted, and I know in radiology this term, it was very common for people to forget to fast dogs. Well, it's very dangerous for animals to have anesthesia or sedation if they ate the morning of anesthesia, because then they have a full stomach. So that is why we tell them not to eat, from the night before, is we want to make sure we have an empty stomach. So normally vomiting can occur when they're first being anesthetized, when they're first losing or regaining consciousness. So at the very beginning of induction or at the end of recovery. But signs that they may have aspirated, you can get an obstruction. They have difficulty breathing, abdominal breathing. Or sometimes what happens, that's such acidic fluid, their bronchi close up and the patient can turn blue. Because what happens is the bronchi spasm closed. And then an animal can try and breathe, but if the airways are spasmed closed, they're not going to be able to oxygenate. So the normal thing to do is to get them intubated. If you're inducing an animal that's trying, let me give you a scenario. I've had students start to induce an animal and it start to vomit. The number one thing I do is I take that dog and first of all, hang them over the table. And I don't care. I've had dogs vomit on my shoe, splat on the floor, but immediately, if you hold that dog's head up and you're like, oh, I don't want you to vomit on me, then it's going to go into their lungs. So you got to get their head over the table, get the vomit, let it drain. I try to wipe their mouth if I can and get them intubated. If they do it on recovery, I try to lower their head and I try to, so you're always lowering the head, try to let it drain, try to get some type of like a towel or something to clean out, but careful they don't bite you, because if they're waking up and you go to stick your hand and clean out their throat, they could bite. So vomiting. If I say what's the first thing you do when a dog vomits under anesthesia, is you have to drop their head lower than their body. Now, post-anesthesia seizures. So a seizure on recovery, remember, ketamine can make it easier for an animal to seize, and sometimes acepromazine. So if the dog has had acepromazine pre-op, if the dog sometimes has had ketamine, or the dog has a history of seizures, you always have to watch them closely. You might start to get twitching, strange neck stretching. Now the problem is when a dog's waking up from anesthesia, they're kind of like, and they might twitch, but this would be like a sustained tenseness, sustained twitching, not just, and it can happen if it's very loud and if they're very excited. So try and keep them quiet. You treat seizures with diazepam, but if you had propofol with you, you could give a dose of propofol. That could work if you didn't have access to Valium. But Valium is the drug of choice. And then depending on how long the seizure lasts, you want to make sure that they don't overheat. Now, excitement, remember when I talked about, I'm drawing a blank. I talked about, emergence delirium. So sometimes when they first wake up, they can get screaming, crying, paddling. That is different. That's not seizure activity. That's excitement. And remember I said, how do you tell the difference? Because usually you can hold them, you can talk to them, and you feel them start to relax. You could give a sedative to calm them down. But the big key here is if you see anything weird, you have to determine, is it a seizure and is it excitement? And the difference is the excitement, the dog's going to start to come out of it, calm down. Seizure, you're going to start to see the chattering, the twitching, the tense legs. It's going to be more seizure-like activity. Okay, so some other problems that we can see is dyspnea during recovery. So now this could be the patient had problems during surgery, or you had a problem, or you had a patient breathe completely normal, and then once you're in recovery, they start having difficulty. And the number one category is, this is always on my mind if I have a brachycephalic because of their airway anatomy. Sometimes due to other anatomy problems or a foreign object, did they inhale a gauze? Did a towel get in there? Or do they have a lot of mucoid discharge? Sometimes patients on recovery, if they made a lot of secretions, then remember I said When we give them atropine to dry up secretions, sometimes it makes secretions very thick. And so we got to worry that sometimes when you go to pull the tube out, some of those secretions are stuck to the tube and get lodged. And the other thing, post-surgical swelling. This is why I'm really, especially in cats, you have to be very careful. You never force a tube in an animal, okay? A lot of times if you can't get the tube in, it's either too big or the animal is still too light. And usually you have to give it a little more anesthetic. Remember, cats can laryngospasm, and so sometimes if you force the tube, what happens is you get laryngeal edema, and edema is a fluid swelling in the tissues. And that has to be treated with, like, usually steroids or something. But if you're worried about breathing, you can have oxygen available via the machine. We have little flow meters that plug into our oxygen source over all of our ICU cages. So we can give oxygen to any patient, which is either in an e-collar, flow by in front of their nose, or a face mask. So read the notes under that slide. Now, sometimes what happens is cats are sensitive with the tube going in. They can be sensitive when you pull the tube. And what happens in a cat, if they laryngospasm, sometimes they stay closed and they can't breathe. You'd obviously have to re-induce the cat to relax them and re-intubate them. But if you keep trying to intubate, you don't want to get this edema. And sometimes they will be wheezing, and a wheezing sound is not growling, because a lot of cats wake up growling because they're pissed and they're cats. But a wheezing is going to be a little bit, and that can be a sign that there's swelling and the air isn't moving. So you may have to intubate, do a face mask, give oxygen. The ultimate emergency is do what's called a tracheotomy or a tracheostomy. And that's what we do is we cut a hole in through the skin on their neck and we open up the airway. Because again, think of it this way, guys. If a swelling is here, closed, you can put a hole here and then they don't have to inhale through here. They inhale through here, okay? But again, let's prevent it rather than treat it. Use lidocaine, use appropriate tubes, don't force them. There's ways to prevent this from happening, okay? Now, the other thing we worry about is prolonged recoveries where they're taking forever to wake up. Like I've told you, if you have an animal that has renal insufficiency or elevated kidney enzymes or liver enzymes, the kidney and the liver are the two organs that really clear anesthetic drugs from the system. If either of those organs are impaired in any way, the problem is they don't clear the anesthetics from the system. The anesthetics stay in circulation. So sometimes these guys sleep a little bit longer. Susceptibility to an agent. Remember when I said sight hounds were sensitive to pentothal back in the day? So a greyhound that got pentothal would sleep a very, very long time. So we started using other drugs. So that's, and then, you know, your patient may have its own sensitivities. They may have another disorder. Sometimes brain tumor patients, trauma patients can be sick. And then, or the longer your anesthesia, the deeper your anesthesia, the longer it's going to take them to wake up. So again, your goal is to keep them, ideally you're be above 96, 97 degrees. Now, like I said, when you guys are in surgery rotation, you can get patients that are lower because your surgeries are taking longer because you're learning. In practice, you know, spays and neuters are pretty quick. But where I came from at Purdue, these surgeries were longer surgeries, more involved surgeries. I had patients that were very cold, sometimes down to 92 degrees when they wake up. So you have to start actively warming them. So the advantage to keep the patient warmer is they usually wake up faster. So, or you kept them too deep during surgery, and then they're also going to take a long time to wake up. So, um, and I will go over this when we talk next week as a kind of a primer. But what you're going to be doing as Dr. Ritz is like, or Dr. Paul, as they're finishing surgery, you know, once the testicles come out or the ovaries come out, you should start to turn down your anesthetic. So by the time she puts in the last stitch, they're almost turned off of gas, is the ideal situation. Okay. All right. So you can read through the key points, read the notes under the slide, and we will Zoom on Friday. Thank you.